Howdy everybody, welcome back to MSK. My name is Jonathan, and today we are starting a new chapter going over the shoulder and elbow. So in this first video, we're just going to go over the shoulder anatomy, where we'll talk about the bones, muscles, ligaments, and articulations involved in the normal anatomy. In the upcoming videos, we'll talk about pathologies of the shoulder. So we'll go over rotator cuff tears, clavicle fractures, and humerus fractures. Then we'll move on to the elbow, and we'll go over normal elbow anatomy, and then we'll talk about epicondylitis, which is the most commonly tested elbow pathology for step 1. Without further ado, let's learn about the shoulder. So we'll start with the bones of the shoulder, and first we'll talk about the scapula, which is the flat triangular bone that'll connect the clavicle and the humerus. So we can see the scapula here, and here's the spine running across, which will eventually become the acromion, which is where the clavicle will attach to the scapula. And then the humerus will attach inside here, what we call the glenoid fossa of the scapula. The clavicle will be the S-shaped bone connecting your sternum and scapula, and this is a really important connection because it's actually what anchors your shoulder to the axial skeleton. And of course, the humerus will be the long bone of the arm that will articulate with the scapula to form the shoulder girdle, as we can see in this close-up right here. Alright, moving on to the muscles, we'll start first by talking about the rotator cuff, which is actually comprised of 4 separate muscles. So for each one, let's go over the origin, insertion, and then understand how those origin and insertion contribute to the action of that muscle. So we'll start with the supraspinatus, and let's understand that this here is the spine of the scapula. So supraspinatus means that this will be our muscle here, supra, above the spine of the scapula. When we think about its action, because it sits so superiorly, when it contracts the muscle, it's going to apply a torque force that's going to abduct the humerus up. And so that's what the supraspinatus does, is that it contributes to shoulder abduction. Importantly, it initiates abduction. So the first 0 to 15 degrees are really dominated by the supraspinatus, and other muscles take over once we get past those 15 degrees. So our next muscle below the spine of the scapula will be our infraspinatus, which is this very broad muscle here. So this muscle will originate on the supraspinatus fossa, which is this shallow depression below the spine of the clavicle, and then it will insert onto the middle facet of the greater tubercle. So if we're thinking about the action of the infraspinatus, I've drawn here a top-down view of what it might look like if we're looking at the infraspinatus interacting with the humerus. Here's our medial side, our lateral side, and our posterior side. So you can see that the infraspinatus is attached posteriorly, and when this muscle contracts, and it's going to put a force on the humerus in this direction, then the humerus will want to rotate outside. And so that's why we see the infraspinatus contribute to external rotation of the humerus. So the teres minor will have a similar action because of its similar position. It will originate on the lateral border of the scapula, and then it will insert onto the inferior facet of the greater tubercle. So because of that similar positioning of it being posterior to the humerus, it will contribute to external rotation in addition to adduction, because it will want to bring that humerus closer to the body. And last, we'll talk about the subscapularis, which is different because it is on the anterior side of the scapula right here. So this muscle will originate on the subscapular fossa and then will insert onto the lesser tubercle of the humerus, which will be more anterior than the previous 3 muscles. So if we look at our top-down diagram, we can see that when the subscapularis contracts, we are going to put a rotational force on the humerus that will internally rotate it, in addition to adduction, and bring that humerus closer to the body. And moving away from our rotator cuff, we have our deltoid, which will be this muscle here. And predominantly, the action we think of with this muscle will be shoulder abduction greater than 15 degrees. But as you can see in this picture, the deltoid has anterior origin points on the clavicle, as well as posterior ones on the scapula. And what that means is that the shoulder can contribute to shoulder flexion and shoulder extension. And lastly, we'll talk about the teres major, which will originate on the dorsal side of the inferior angle of the scapula, and then insert on the intertubercular groove of the humerus. Importantly, that insertion point is very different from the shoulder cuff muscles here. Because that teres major muscle will go to insert more anteromedially than the teres minor or the infraspinatus, this muscle will actually contribute to internal rotation and adduction. As we can imagine, if this muscle were to contract, it would provide an internal rotational force on the humerus. All right, now we'll move on and talk about the ligaments of the shoulder. Now, it's important to understand that in the grand scheme of all things for step 1, knowing names of ligaments is relatively low yield. But as a future doctor, it's not a bad idea to go over it and understand the naming conventions and the anatomy. And as you can see, the ligaments are conveniently named after what structures they connect. So the glenohumeral ligaments will be connecting the humerus and the glenoid fossa of the scapula. The acromioclavicular ligaments will attach the acromion to the clavicle here. The coracoclavicular ligaments will connect the coracoid process here to the clavicle here. And the transverse humeral ligament will be this small ligament here that will help keep the biceps tendon in place along the humerus. And finally, we'll talk about articulations, which will follow a similar naming convention to the ligaments. So the glenohumeral joint will be the joint between the glenoid fossa of the scapula and the head of the humerus, which we can see in a close-up here, where we can tell it is a ball and socket joint, giving us great mobility at the cost of some stability in the shoulder. The sternoclavicular joint will be between the medial end of the clavicle and the manubrium of the sternum, which we can see here. And again, this is the point that anchors the shoulder to the axial skeleton. The acromioclavicular joint will be between the lateral end of the clavicle and the acromion of the scapula, which we can see here in this close-up view. And the last joint we'll talk about will be the scapulothoracic joint, which is between the scapula and thoracic wall. But importantly, this is not a true anatomical joint. Anatomical joints, like the glenohumeral joint, typically have things like cartilage and ligaments to anchor the bones together. But the scapulothoracic joint doesn't have those, so we really just consider it a physiological joint. All right, let's do a recap, and then we'll do a practice question together. The three important bones of the shoulder will be our scapula, our humerus, and our clavicle. The muscles of the shoulder will include the rotator cuff, which will have our supraspinatus, infraspinatus, teres minor, and subscapularis, giving us our sits mnemonic, as the rotator cuff sits on the scapula, in addition to the deltoid and teres major contributing to actions at the shoulder. There are several ligaments of the shoulder which are all at risk of injury and are often named by the two bones that they attach. And the joints of the shoulder include the glenohumeral, the sternoclavicular, acromial, and the physiological joint, the scapulothoracic. And a practice question might sound something like this. A 37-year-old male comes into your clinic complaining of left-sided shoulder weakness. In addition to the weakness, the patient reports a painful sensation with activity which he first noticed while pitching during baseball practice 2 weeks ago. Vital signs are within normal limits. On physical exam, you notice that initiation of abduction on the left side elicits pain and is difficult for the patient. But when abduction is initiated at 30 degrees, the patient reports that there is reduced amounts of pain. Based on the presentation, what is the most likely injured muscle in this patient? Because this patient struggles with shoulder abduction, both the deltoid and the supraspinatus are possibly injured in this patient. But because the patient struggles with initiation more than after the 30 degrees, we can likely rule in that the supraspinatus is more likely to be injured in this patient. All right, that's everything from me today. Thanks for watching. Good luck studying, and I'll see you next time.